Welcome to the deep dive. Today we're going through a stack of source material on the medical illness of depression, specifically major depressive disorder MDD and also persistent depressive disorder or PDD.
And we should say right at the top, it's really hard to put into words the sheer agony and exhaustion that comes with a severe depressive episode.
It is. So our mission here is to just, clarify the landscape for you. MDD is what most people picture.
Right, that persistent sadness, the low energy, and just a total loss of interest in, well, everything you used to enjoy.
And PDD.
PDD, which used to be called dysthymia, is often a bit milder, but it's much more chronic. It's a kind of low-grade, long-term state.
The scale of this is just staggering. What are the key numbers we really need to hold on to here?
The lifetime prevalence for MDD is huge. It hits 28.2%. But, the most sobering detail for me was that diagnoses have been confirmed in kids as young as 3.
3 years old. Wow.
And if you look at teenagers, say 12 to 17, the relapse rates after they recover from an episode are somewhere between 30 and 70%.
70%. That's a crushing number. It shows that recovery is just the first step.
It's just the start of the battle.
Absolutely. So that begs the question, how does this even begin? What's the leading theory on how environment and biology connect here?
The sources really dig into the stress diathesis model. And the key thing for you to take away from this is that depression isn't a moral failure. It's not just being sad.
It's a real biological vulnerability.
Exactly, the diathesis. And that gets triggered by stress from the environment, from major life events.
So what are those biological factors? We're talking genetics, but also brain chemistry.
Yes, the biochemical side centers on what are called the monoamines. Things like serotonin, norepinephrine, and dopamine.
Crucial messengers in the brain.
And when their regulation is off, that's central to the theory of depression. And you have to realize the risk factors are so specific. The sources list family history, chronic medical illness, a history of sexual abuse, and being part of the LGBTQ community.
So let's pivot to what works. Let's talk medication. The sources make this crucial comparison between the newer SSRIs and the older TCAs.
And it's really a fascinating trade-off. The SSRIs are, generally speaking, much safer in an overdose and just better tolerated.
And I saw they're good for depression with anxiety, too.
They are, but they come with common side effects like sexual problems or agitation, which can be a real issue.
And the TCAs are powerful, but they have heavier baggage.
They do. Very effective.
Yeah.
But they have cardiotoxic side effects. They can put a serious strain on the heart.
Which is risky for older patients.
Or anyone with a heart condition. But the most critical safety warning from the sources, it's about the MAOIs.
Monoamine oxidase inhibitors.
Yeah.
Right, that class requires extremely careful management. Why are they such a clinical landmine?
They're powerful, often used when other drugs fail, because they stop the body from breaking down those key neurotransmitters.
So levels go way up.
Dramatically.
Yeah.
But the danger is in common foods. You need a strict diet, no aged cheese, no cured meats. Because combining them with something called tyramine can cause a sudden, lethal spike in blood pressure.
A hypertensive crisis.
Which can lead to a stroke or even death.
So safety is always priority one. And that brings us to assessment. What tools did the material highlight?
The Bic Depression Inventory and the Hamilton Depression Scale are really the gold standards there for quantifying symptoms. But with extreme depression, just talking can be the biggest hurdle.
Their speech can slow right down.
Or they might be completely mute. And the sources emphasize that just sitting with a patient in silence, being present without pressure, can be a really valuable and meaningful intervention.
It acknowledges their internal state without demanding anything.
Exactly.
And beyond medication, let's just quickly run through the other evidence-based treatments mentioned. It was a long list.
It's important for you to know the spectrum is wide, yeah. You've got therapies like CBT, which focuses on thought patterns, and IPT for relationship dynamics.
And then the somatic treatments.
Right, for treatment-resistant cases, things like ECT, VNS, TMS, and light therapy.
Okay, so here's where it gets really interesting and something for you to take with you. The sources had this chilling case study.
I remember that one.
It was about a young patient starting medication. And the scary takeaway is that when the meds start to give a person the energy to act, but not yet the improved mood, that window is critically dangerous.
Precisely.
So for you, the listener, consider this implication. A sudden lift in mood, that burst of energy early in treatment, might actually be a sign that you need to increase safety vigilance, not relax it. It just highlights the profound complexity of the very first steps of recovery. Welcome to the deep dive. Today we are jumping into one of the most complex mental health conditions out there, bipolar spectrum disorders, or BSDs. Our mission today is pretty simple, really. We want to give you the clinical shortcut for identifying the spectrum of illness and, maybe more importantly, understanding the high-stakes strategies used to keep people safe when symptoms spiral, all pulled from specialized medical sources.
And that's so crucial because these are chronic recurrent illnesses. They exist on this whole continuum, from crippling depression to periods of intense manic energy and these really painful mixed states in between.
And when you say spectrum, you're talking about the main categories, right? Bipolar I and bipolar II.
Exactly. Bipolar I and bipolar II and cyclothemic disorder. For you to understand the diagnosis, the key difference really comes down to that high energy state. Bipolar I needs a full-blown, debilitating manic episode. For bipolar II, it's hypomania, so it's noticeable, but the person might still be functioning, sort of.
Okay, so let's unpack that. When a doctor sees a patient who presents with depression, what's the big red flag that makes them think, hang on, this might not be unipolar depression, this could be on the bipolar spectrum?
It's interesting. The surprising nugget is often the comorbidity.
Comorbidity. So other conditions happening at the same time.
Right. If you have a patient with depression who also really struggles with substance use, or they had a very early age of onset, you have to screen for bipolar. The data suggests that link is just. It's incredibly strong.
And are there specific symptoms within the depression itself?
Oh, yes. Bipolar depression often involves things like psychomotor retardation.
Which is what exactly?
It's a physical slowing down. I mean, everything is difficult. Patients describe it like trying to wade through molasses.
And the numbers behind this tell a pretty surprising story about who gets affected. The lifetime prevalence is around 4.4%, which is pretty significant, and the average onset is so young, about 18 years old.
It is. And we also see that bipolar II is disproportionately female. It's almost 2 women for every man affected.
So that's the depressive side. What about the other side of the coin? What happens when the mood and energy shift into complete overdrive?
Mania exists on its own extreme range. You can have hypomania, which can actually feel good to the person experiencing it.
Yeah.
But the severe end is what's called delirious mania. And people often don't realize this, but it can actually be fatal.
Fatal? How?
Just from pure physical exhaustion.
Yeah.
Think about it. Nonstop activity, absolutely no sleep, refusing to eat. The body literally just gives out.
That's incredible. And what's fascinating is the behavioral description our sources give. They say these individuals can be incredibly manipulative and almost adept at finding the vulnerabilities in other people during this phase.
Yes, and their communication style is a huge diagnostic giveaway.
You mean like the pressured speech?
The pressured speech, exactly.
Yeah.
They feel compelled to talk constantly. And you'll often see that with what we call a flight of ideas.
Yeah.
Or they might use clang associations.
Clang associations.
It's when they choose words based on how they sound, not what they mean. So just rhyming uncontrollably. And the content of what they're saying is often sexually explicit. Or it's all about grandiosity and paranoid delusions.
You see that perfectly in the case study of Mr. Kwong. He was found shouting, wearing a robe with peacock feathers, proclaiming, I own the whole movie industry, I have billions.
A textbook merger of grandiosity and psychotic features, that's bipolar I.
But facing someone with that level of acute agitation, how do clinicians even manage that situation without just triggering a huge conflict?
That is the challenge. The number one priority is de-escalation. You have to use a firm but incredibly calm approach.
So avoid power struggles.
At all costs. You have to stay neutral. The most effective tactic is often just distraction, using short, concise statements to channel that frantic energy somewhere else.
Okay, let's talk about a critical medication challenge. Lithium is a foundational treatment, but what's the big danger sign everyone needs to watch for?
Lithium's therapeutic window is razor thin.
The difference between a helpful dose and a toxic dose is minimal.
Exactly, so it requires constant blood monitoring. But here's the key insight. Low sodium levels can precipitate lithium toxicity.
So if you get dehydrated or sick, and your sodium drops.
Your lithium level can spike into a dangerous range. You have to watch for increased nausea, vomiting, slurred speech, or muscle weakness.
Wow.
You see that, you hold the dose immediately. It's an emergency.
So when we put all this together, it's clear BSDs are just biologically complex. It's this interconnected web of genetics, environment, and neurochemistry.
It is. It's a true lifetime commitment to manage. And the final crucial takeaway is that just getting stable isn't the end of the fight. We know now that up to 1/3 of patients battle significant, persistent cognitive difficulties even when their mood is stable.
You mean like problems with focus or memory?
Exactly. And that's why prevention strategies have to be more than just medication. They need to include treating even subclinical,
depressive symptoms, and specifically bringing in things like aerobic physical exercise. Just consider how fundamental those lifestyle factors become in managing this for the long haul.
Welcome to the deep dive. Today we're tackling the stack of sources you sent us on schizophrenia spectrum disorders.
Right.
And our mission really is to cut through some of that complexity. We want to understand the core of this disease and pull out some humane, actionable ways to communicate.
And it's a deep dive that affects, what, about 1% of the world's population? It's the primary psychotic disorder.
1%. That's a lot.
It is. And what the sources really crystallize is that schizophrenia is, at its heart, a breakdown in the brain's actual infrastructure.
Infrastructure, so it affects how a person thinks, feels, and behaves.
Exactly.
That's really the key takeaway, isn't it? It's a biological problem that just presents as a behavioral one. And you mentioned a breakdown. We're talking about those 5 core symptomatic domains.
Yep. Delusions, hallucinations, the disorganized thoughts, motor behavior, and then, negative symptoms, which are often much more complex.
And the biological evidence is pretty solid for this, right?
Well, it's substantial. I mean, we see actual structural brain abnormalities like decreased tissue volume and larger ventricle.
Wait, so if the structure is damaged, how does just treating the neurochemistry even help?
Well, that's because the etiology is so complex. It's multifactorial. You have clear disruptions in the signaling systems.
Okay, so we're talking neurotransmitters.
Specifically, dopamine, serotonin, and glutamate at the NMDA receptors seems to play a key role.
And it's not just one bad gene either.
Not at all. The research points to about 42 genes all working together.
42. So that explains why there's no simple silver bullet drug.
Precisely. And I think the sources also mentioned synaptic pruning.
Right. Which sounds super technical, but it's basically the brain's normal wiring process going a little off track during development.
That's a great way to put it. Spot on. And that developmental timeline seems to be critical for prognosis.
That part was fascinating because an earlier onset, that often means more prominent negative symptoms and generally a poorer prognosis.
But if you see a later onset, say between 25 and 35.
Which is more common in females, right?
Yes.
Yeah.
And it's often linked to, well, better long-term outcomes.
Okay, so let's quickly nail down those symptoms then. The sources make a big distinction between positive and negative.
A critical distinction. Positive symptoms are the added experiences, the things you see in movies, hallucinations, paranoia, delusions.
And the negative symptoms are the losses of function. And these are often the most debilitating parts of the disease.
Absolutely. We're talking about apathy and hedonia.
That's the clinical term for being unable to feel pleasure, yeah.
Correct. And just a general profound lack of motivation. Then you have the cognitive symptoms, like impaired memory, and of course the mood symptoms, depression, suicidality. It's a heavy burden.
So given this profoundly altered reality, what do the sources say about how we connect? How do we communicate with someone in an acute phase?
The main thing is safety and trust. And that starts by acknowledging their reality, even if you can't share it.
What does that look like in practice?
With hallucinations, the best intervention is to just ask directly, are you hearing voices?
Just straight out.
Just straight out. You accept the voices are real to them, but you state calmly, I don't hear them. Then you try to refocus the conversation on something simple, something reality-based.
And for delusions or paranoia, arguing seems like it would be the worst possible thing to do.
It is. Never argue.
Yeah.
It just feeds into and validates the belief system. The sources suggest a more matter-of-fact, almost business-like approach.
And they get really specific, too. I remember reading about the seating arrangements.
Yeah, for intense paranoia, avoid sitting face-to-face, minimize direct eye contact, even offer food or drinks in, like, closed containers to reduce fears of contamination.
Wow. That level of detail, it just shows how critical building trust really is.
It's everything.
So, okay, let's unpack this. We've gone from complex brain chemistry and 42 genes all the way to these very specific compassionate communication strategies.
It's a holistic challenge. And if we connect this to recovery, the outcomes are best when the goals are mutually agreed upon by the patient and staff.
Like in the NIMH's RAISE project.
Exactly. The recovery after an initial schizophrenia episode project. It showed huge improvements in symptoms and quality of life with early, focused care.
And what stands out to me is how the sources redefine what success even looks like. It's not just about no symptoms.
No, recovery is defined across 4 dimensions: health, home, purpose, and community.
So here's the final thought for you to take away.
Knowing that recovery is defined by these dimensions, health, home, purpose, and community, how does shifting the focus from just symptom reduction to these broader life goals change how we view and support long-term recovery? Something to think about until our next deep dive. Welcome to the deep dive. Today we're jumping into a really important topic, neurocognitive disorders. We're going to try and untangle the difference between the rapid temporary conditions and the ones that are unfortunately progressive.
And to do that, we really have to start with cognition itself. What is it?
Right.
Simply put, it's just how we process the world. It's our mental machinery for acquiring knowledge, for understanding things through our senses and experiences.
And it impacts everything, your physical life, psychological, social.
Absolutely everything. And it's not just one thing. Our sources break it down into 6 key domains. Things like complex attention, your executive functioning.
That's like planning and decision-making.
Exactly. And then you have learning and memory, language, perceptual motor skills, and social cognition. When these start to falter, you're generally looking at one of 3 main categories.
Okay, so what are they?
Delirium, which is transient, mild NCD, and then major NCD, which is what most people think of as dementia.
Let's start with delirium. You called it transient, and the sources say it's like an urgent fire.
It really is. And the key thing to remember is that delirium is always secondary to something else.
So it doesn't just happen on its own.
Never. It's caused by a medical issue, maybe substance withdrawal, a reaction to medication. Something external is triggering it.
And the onset is incredibly fast. We're talking hours or days, not months or years.
Yes, and the symptoms fluctuate. They can be much worse in the evening, which is that sundown syndrome people might have heard of.
I was shocked by the prevalence numbers.
Oh, they're huge. Up to 53% of older adults after surgery. And in the ICU, it can be as high as 70 or even 87%.
Wow.
It just shows how vulnerable our cognitive state is when the body is under extreme stress.
And it's not always the agitation you might picture, right? There are different types.
That's right. There's hyperactive, which is that agitation,
Mhm.
but there's also hypoactive, where the person is withdrawn and quiet, and that one is often missed.
So the goal is to find that underlying cause and treat it fast.
Urgently. Safety is the #1 priority. You never, ever leave a person in acute delirium alone. The long-term goal is to get them back to how they were before, back to their normal baseline.
Okay, so if delirium is a reversible fire, let's switch to the slow burn, major NCD, or Alzheimer's.
Right. This is a much more gradual development. And with Alzheimer's, the problem is happening inside the brain tissue itself.
This is where it gets really fascinating on a microscopic level.
It is. You have 2 things going on. Amyloid plaques are forming between the brain cells, and neurofibrillary tangles are forming inside them.
This combination is just devastating.
It kills the connections, the synapses, and it really damages the hippocampus, which is critical for memory. Over time, the brain tissue actually shrinks.
So what does that look like in practice? The sources had a helpful mnemonic, the 4 A's.
Yes, it's a great way to remember the core symptoms. First is amnesia or memory impairment.
The one everyone knows.
Right. Then you have aphasia, which is trouble with language. Apraxia is difficulty with learned motor movements, like buttoning a shirt. And finally, agnosia, the inability to recognize familiar objects or even people.
And as this happens, people naturally develop coping strategies, almost like defense mechanisms.
They do, unconsciously. We see things like denial, of course, but also confabulation, which is really interesting.
That's where they make up answers to fill in memory gaps.
Exactly. But it's not lying. It's an unconscious attempt to maintain their self-esteem. We also see perseveration, which is repeating a word or action over and over.
From a care standpoint, though, what's the single highest priority in the late stages?
It always comes down to risk for injury, always.
Which brings us to communication. If you're talking to someone with an NCD, what are the key takeaways?
Keep it simple, speak slowly, use short words, and always maintain face-to-face contact. Be present with them.
And what if they're experiencing a delusion? Arguing with them seems like it would just make things worse.
It absolutely does. You never, ever refute the delusion. The rule is to acknowledge the feeling behind it. That sounds really frightening. And then gently reinforce reality. You're safe here with me.
We have to touch on the pharmacology because it's a hard reality. There's no cure for Alzheimer's.
No, the drugs we have, like cholinesterase inhibitors, they don't reverse the damage. They just, for a limited time, can delay the symptoms from getting worse. They're a management tool, not a fix.
And that reality puts a huge, huge burden on caregivers.
An immense burden. And that's why community support is so critical. Things like adult daycare, Meals on Wheels, respite services, they aren't just for the patient. They are essential for keeping the caregiver from burning out.
So when you boil it all down, what's the big picture here?
The core distinction is everything. Understanding if you're dealing with the transient nature of delirium or the progressive nature of major NCD completely changes the goal.
Reversal versus management.
Precisely. For delirium, the goal is a full return to their normal self. But for progressive NCDs, the focus shifts. You're trying to maximize what they can still do and minimize their anxiety. You make sure tasks are simple enough that they can succeed.
And that leaves us with a final sort of provocative thought.
It does. It raises this really important question for all of us to think about. How do you define success when the goal is no longer recovery, but is instead about maintaining dignity through a person's decline? Welcome to the deep dive. Today we're doing a really focused deep dive into substance-related and addictive disorders, or SUDs.
We've gone through the source material on the biology, the diagnosis, and the treatment.
Our mission is pretty simple: to give you the absolute shortcut to being informed on this.
Yeah, the essentials.
I have to say, I was surprised the sources started the conversation so broadly. When we talk about psychoactive drugs, we're not just talking about illegal stuff.
No, not at all.
We're talking about massive categories like alcohol, nicotine, even caffeine and marijuana. Why start so wide?
Because the underlying mechanism, it's pretty much the same. And these substances, they cut across every single social and economic line.
Okay.
But the core concept you really need to walk away with is this. Addiction is not a moral failing. It's a chronic, relapsing brain disease.
A brain disease.
Yes. It's defined by that compulsive drug-seeking behavior, and it's tied to clear, measurable, long-lasting changes in the brain.
That one idea completely reframes everything, doesn't it? So, knowing this is fundamentally a brain disease, what do the sources tell us about the scale of the problem?
Well, the prevalence is pervasive. In the U.S., alcohol is consistently the drug most used.
Followed by marijuana.
Right. And what's really fascinating here is the sheer level of comorbidity. You almost never see SUD in a vacuum. There's a very high risk of dual psychiatric diagnoses.
And severe medical issues, too, I saw. Things affecting the CNS, the heart, the gut.
Exactly.
Okay, so let's unpack the mechanism. If the brain is being hijacked, what part of the brain are we talking about? Why is recovery so incredibly difficult?
It all starts in the limbic system. You can sort of think of it as the brain's old original survival computer.
Driving the need for reward and pleasure?
Precisely.
Yeah.
And all addictions, regardless of the substance, they all centrally involve the neurotransmitter dopamine. Dopamine regulates our emotions, our pleasure, our pain.
And this is where it gets really interesting. How does the addiction actually break that system?
Drug use makes the whole dopamine system less effective, less responsive to natural pleasures, things like food or exercise.
So the brain is essentially resetting its pleasure baseline downward.
Exactly. And that leads directly to tolerance and dependence. The person needs more and more of the drug just to get back up to a neutral functioning baseline, not even to feel high.
Just to feel normal.
Just to feel normal.
And we should quickly note that some substances like alcohol have a specific action, right? They act on GABA.
Right, which is the neurotransmitter that inhibits and protects our receptor nerves.
So if the biology is the cause, how do we spot this in the real world? What are the key clinical flags from the DSM-5 we should look for?
You don't need all 11 criteria memorized, just the big indicators.
Most importantly, craving, that overwhelming compulsive urge.
Absolutely. Then there's continued use despite knowing it's causing a persistent physical or psychological problem.
And the really critical one, recurrent use in situations that are physically hazardous.
And of course, if you see tolerance and withdrawal, that pretty much seals the diagnosis of a substance use disorder.
Okay, so let's move into treatment. The sources really emphasize that recovery is a process defined by 4 pillars: health, home, purpose, and community.
Which means treatment has to be comprehensive. It's got to address everything at once: medical, social, legal, psychological needs.
What really stood out to me was the concept of harm reduction.
Yes. These are proactive strategies that kind of buffer the community from the full impact of addiction. It's like a critical safety net.
Things like methadone maintenance programs, needle exchanges.
And critically, making naloxone, or Narcan, easily available to reverse opioid toxicity on the spot.
We also have medication-assisted treatments. But instead of just a list, what do these medications actually do?
Well, they generally fall into 2 buckets. For alcohol, You have drugs like naltrexone that can block the reward pathway, basically making drinking feel pointless.
And others, like disulfiram, that create a bad physical reaction.
Exactly. And then for long-term opioid management, methadone and buprenorphine stabilize the brain chemistry to stop cravings and withdrawal. That allows the person to actually pursue recovery.
So, what does this all mean for you? I think the primary takeaway is that SUD is a specific measurable condition rooted firmly in neurobiology.
And that successful treatment has to address any co-occurring psychiatric disorders at the same time.
Right.
The source material mentions a really concerning data point. An estimated 10% to 20% of all nurses in the U.S. are addicted to some substance,
Wow.
which creates a clear ethical obligation to report impaired practice.
So if knowledge, like we've discussed, is most valuable when it's understood and applied, consider this. How does this knowledge about addiction being a chronic brain disease reconcile with the ethical obligation to report professionals? And what systems do we need to ensure the focus stays on non-judgmental, individualized care while maintaining absolute public safety?
It's a tough question.
It is. That's something to mull over.